Now it's my turn. I'm Xuan from Peking Union Medical College Hospital. Thank you for your nice presentation about the EGFR TKI treatment for the first line EGFR mutant non-small cell lung cancer. One of my first comments is about the first line treatment for this kind of patients. I think the third generation EGFR TKI is very widely used in EGFR mutant non-small cell lung cancer patients. For patients who harboring EGFR X21 L858R, or for patients with brain metastasis, I agree with you. We can add the chemotherapy as the first line treatment. But I also have the same comments with Professor Zhang, and how many cycles of chemotherapy will be enough? One of my patients harboring EGFR X20 mutation, and she is a very young female. In the very beginning, I added four cycles of chemotherapy plus with osimertinib in total, and then the patients got a very good response from the combined chemotherapy and osimertinib therapy. But I think maybe 4 or 6 cycles of chemotherapy will be enough. So I stopped the chemotherapy, and now the patient was with a very good quality of life. And so I think maybe we can just like the checkmate. I forgot the trial. Maybe limited chemotherapy will be enough. And when these patients got resistant from the EGFR TKIs, we can use the chemotherapy as a second-line treatment. I think it will be a good strategy. And another of my comments about the patient with EGFR mutant patients who is potent to get the operation, and for this kind of patients in the neoadjuvant therapy, I think maybe the chemotherapy plus with immunotherapy will be good for this kind of patients. In the previous trials, Keynote 671, and this kind of patients were not excluded from the study, but for the patient trials, Checkmate 816, this kind of patients was not enrolled. And we found that for patients harboring EGFR mutation, they can benefit from the neoadjuvant chemo plus immunotherapy, and the PCR rate is very high. But for this kind of patients who received EGFR TKI as the neoadjuvant therapy, the PCR rate is very low. So I think this kind of patients can be benefit from the immunotherapy plus with chemotherapy neoadjuvant therapy. But what will be used as the adjuvant therapy, EGFR TKI or immunotherapy? That's my first questions. And another question about for patients harboring ALK positive rearrangement. We found that for the ALK positive non-small cell lung cancer is totally from the EGFR mutant patients. For example, for patients harboring ALK allergen, they can benefit from the ALENA study style treatment. But what treatment should be used as the neoadjuvant therapy? Yesterday, I have a patient with ALK positive IHC D5F3, and the PD-L1 expression is also very high, as high as 19%. But these patients may be benefit from the neoadjuvant therapy, and then I think she can, after the neoadjuvant therapy, maybe she can receive the operation, which will be chosen as the neoadjuvant therapy for these ALK positive patients. That's my second question. Thank you.
Thank you very much, Professor Yan. And I think I think they're both very interesting points. I think the question of EGFR mutant disease and use of chemoimmunotherapy is still to be answered, I think. And realistically, it's probably best answered in Asia, where there's a high incidence of EGFR mutant disease. It would be quite difficult to accrue a trial, for example, of neoadjuvant chemoimmunotherapy in the West. The concerns that people have expressed, I guess, about giving neoadjuvant chemoimmunotherapy is, do you lose out on the potential benefit from adjuvant EGFR TKI, because there is this kind of interaction in terms of toxicity between anti-PD-1 and osimertinib, for example, where there appears to be enhanced toxicity if you have recently received immunotherapy when you go on osimertinib. So I think that's one concern. I think you can obviously wait and potentially wash out after the neoadjuvant therapy. In terms of the actual data, the number of patients in KEYNOTE-671 with EGFR mutant lung cancer was quite low, I think about 4 or 5%. The best data we've seen probably is from the EMPOWER-010 trial, which was the adjuvant atezolizumab trial. And the hazard ratio for patients who had PD-L1 high EGFR mutant disease in that setting did appear to favor atezolizumab. So I think that's the most interesting data we've seen with immunotherapy for EGFR mutant disease in these large phase 3 trials. So those patients with PD-L1 high EGFR mutant disease in the adjuvant setting perhaps may benefit. But on the other hand, we also have the ADARA data. So I don't have a good answer there. We have been tending to exclude EGFR mutant disease from neoadjuvant chemoimmunotherapy, at least in the US. And we will, at ASCO this year, there is the one of the lung cancer oral presentations is the NeoADARA trial, which Dr. Chaft will be presenting, and that's neoadjuvant osimertinib, neoadjuvant chemo-osimertinib, or neoadjuvant chemo. I think those are the 3 arms of that trial. So it will be interesting to see if that trial, I suspect, as you say, the pathologic complete response rates will be quite low, but I guess the question is, will the PFS or event-free survival be prolonged? In terms of ALK-positive disease, again, I think the situation you describe is a difficult one, particularly for stage 3 disease. So a patient presenting with ALK-positive clinical stage 3 disease, what do we do for that patient? Traditionally, we would give some form of neoadjuvant treatment, but do you give an ALK TKI? Do you give potentially a TKI plus chemo, which would be quite an intensive treatment? Or would you think of chemoimmunotherapy? I personally, I don't tend to use immunotherapy for ALK-positive disease at all, and I wouldn't use it in the neoadjuvant setting, I think. But I would consider either a neoadjuvant TKI, so alectinib, or perhaps even alectinib plus chemo for a very fit patient. But we don't, it's kind of a data-free zone. We don't have good data to guide us. But those would be the things. I have had that scenario come up in the past, and we've generally gone with neoadjuvant alectinib and then pursued resection later for stage 3 disease.
Okay, thank you for your answer. Thank you.
Mm-hmm.